Modern medicine often treats heart disease like a warranty expiring. You hit age 50, your doctor runs a scan, prescribes a statin, and concludes your arteries are simply showing their age. The pathological record shows something different. The initial signs of arterial plaque don't appear in middle age, they appear before birth. In a study examining the aortas of prematurely deceased fetuses, researchers found distinct fatty streaks and oxidized LDL particles already forming in the tissue. These lesions were significantly more extensive in fetuses whose mothers had high cholesterol during pregnancy. Those initial formations are not permanent. Postnatal studies tracking young children show that if their lipid environment normalizes after birth, these early fetal lesions actually regress. If infants are born with the beginnings of plaque, and 85% of adults over 50 carry measurable signs of it, we have to rethink how we define the disease. We need a clear way to separate normal human aging from deadly pathology. To find that boundary, we have to look closely at the environment of a healthy human artery before any disease takes hold. This diagram shows a cross-section of an artery naturally thickening along a curve. This is called adaptive intimal thickening. It is a biological reinforcement against the mechanical stress of blood flow, and it contains 0 retained lipids. This is a healthy adaptation. The environment changes when a specific particle called apolipoprotein B, or apoB, enters the picture. These cholesterol-carrying particles cross the endothelial barrier and become lodged in the subendothelial matrix. The body response known as an intimal xanthoma. The physical thickening of the artery wall is a normal biological mechanism. The retention and modification of apoB particles is the exact point where that adaptation crosses the line into actual disease. Tracking this process into adolescence shows a clear trajectory. Autopsy programs examining young adults who died of external causes found that early plaque progression begins silently in youth, steadily accumulating year by year. But historical data created a massive point of confusion. In the 1950s, the famous Enos study examined American soldiers killed in the Korean War and reported that 77% of these young men already had gross evidence of coronary disease. When medical examiners look at modern casualties from Iraq and Afghanistan, the reported rate of coronary atherosclerosis is drastically lower, sitting around 8.5%. This diagram shows the source of that discrepancy. Pathologists in the 1950s examined unfixed, collapsed arteries without internal pressure. Without that pressure, a normal adaptive intimal thickening bulged inward, creating an artifactual protrusion that looked like a blockage. They misclassified a healthy adaptation as severe atherosclerosis. Under modern grading criteria, true lipid-retaining lesions in young adults do increase sequentially, but they map directly onto measurable risk factors like high non-HDL cholesterol and smoking rates. Coronary disease has not vanished from the young adult population over the last 60 years. It predictably and quietly builds throughout early life, a reality that was obscured by decades of misinterpreted medical data. Fast forward to middle age, and the clinical outcomes diverge sharply. Some 50-year-olds suffer catastrophic plaque ruptures, while others maintain clear arteries. This graph displays the cumulative exposure model, which calculates the area under the curve of a person's apoB levels across decades. Plaque burden is not determined by an individual's biological age, but by the total integral of their apoB concentration over time. The mechanism works exactly like cigarette smoking. Just as a physician calculates lung cancer risk by tracking total PAC years, cardiovascular risk is a direct function of cumulative apoB years. We can test this cumulative model against the historical record. The Horus study performed whole-body computed tomography on 137 pre-industrial mummies, spanning 4 millennia. They found arterial calcification in 34% of these ancient remains. Their pre-industrial environments exposed them to heavy burdens of chronic infection, parasites, and indoor particulate smoke, all inflammatory stressors that drive up the retention of atherogenic particles over a lifespan. We see a contrasting outcome in the modern Tsimane foragers of the Amazon. Despite living with high chronic infectious burdens themselves, 85% of Tsimane adults over the age of 40 have a coronary calcium score of exactly 0. The Tsimane maintain this resistance to calcification because their lifelong baseline exposure to apoB particles remains incredibly low. Time alone does not damage the human artery. The structural failure we associate with getting older is driven by the total accumulation of apoB over those years. The SCAPIS cohort study confirms that 42% of middle-aged adults have detectable subclinical plaque. But having microscopic plaque is not the same as having a blocked artery. In that same cohort, only 5.2% had significant stenosis. Statistical ubiquity in an aging population does not equal physiological normality. Reducing lifetime exposure prevents that progression. Clinical trials show that early dietary interventions like pediatric fat restriction and plant-based portfolio diets safely lower apoB without impairing growth or neurodevelopment. And despite the contemporary debate surrounding polyunsaturated vegetable oils, the clinical data points in a specific direction. A Cochrane review pooling over 56,000 participants found that substituting saturated fat for polyunsaturated fat actually reduces cardiovascular events. An artery protected from high apoB concentrations over a lifetime retains its structural integrity well into old age. The capacity to retain lipids is a built-in feature of the human artery, but the progression to obstructive plaque and fatal ruptures is not. By lowering apoB early and keeping it low, we move away from managing a disease of old age and focus instead on preventing it.